Hi, everyone, and welcome. My name is Allison Moser, and I'm a hepatology nurse practitioner at Rush University Medical Center in Chicago, Illinois. In today's episode, I'm focusing on one of the most impactful and sometimes most challenging aspects of MASH management, diet and nutrition. We oftentimes tell patients to lose weight, but for long-term liver health, that's just the starting point. So let's talk about what to actually recommend, how to tailor those recommendations, and tools that we can use to support adherence, especially in diverse populations. The strongest evidence supports the Mediterranean diet, and for good reason. It's rich in fruits and vegetables, whole grains, legumes and nuts, healthy fats like olive oil, moderate amounts of fish and poultry as well. And this diet is anti-inflammatory, low in added sugars, and associated with improved insulin sensitivity, all which are key in MASH. Studies have shown it can reduce hepatic steatosis even without weight loss and improve metabolic parameters that drive disease progression. Other diets that have some emerging evidence include DASH, especially in patients with hypertension, plant-based diets with attention to protein needs, low-carb or more moderate carb diets, especially in patients who have poorly controlled type 2 diabetes, but the emphasis should always be on whole foods, reducing added sugars, and limiting saturated fats as well as ultra-processed foods. I tell my patients that ultra-processed foods are anything that when you turn the package over and you look at the nutrition label, it has more than 5 ingredients, such as chips, cereals, cookies, pops, or soda. So how can APPs tailor diet recommendations considering cultural preferences, socioeconomic factors, food accessibility, and patient comorbidities? Well, personalization really matters. We can't approach every patient with a rigid version of the Mediterranean diet and expect it to work across all cultures, income levels, or health conditions. Our recommendations need to be realistic, respectful, and adaptable. Let's start with cultural food preferences. The goal isn't to replace traditional foods, it's to work within those traditions. Here are a few practical food swaps or adaptations I often use. In Latin American diets, tortillas are a staple, and there are some great ways to make them more liver-friendly without asking patients to give them up. Swapping flour tortillas for corn ones, which are lower in calories, higher in fiber, as well as less processed. Even better, look for 100% whole grain tortillas or homemade versions that have minimal ingredients. And if patients are open to trying alternatives, you can suggest sprouted grain or low-carb, high-fiber tortillas. And if someone typically eats multiple per meal, then you can suggest starting with one, loading it with veggies, lean proteins, or avocado for satiety. In African or Caribbean diets, choose grilled or stewed meats over fried, incorporate more leafy greens, and use traditional spices in cooking techniques while cutting back on added oils or salt. In South Asian diets, swap ghee with smaller amounts of canola or olive oil. Emphasize lentils, chickpeas, and vegetable curries. Use whole wheat roti instead of white naan or refined rice. In East and Southeast Asian diets, use brown rice or black rice instead of white. Promote steamed or stir-fried vegetables. Choose tofu, tempeh, or fish as lean protein sources, and limit high-sugar sauces like hoisin or sweet and soy. By making these kind of swaps, we're not asking patients to give up their food identity. We're helping them make familiar dishes more liver-friendly. Now, on to socioeconomic factors. If someone has limited income or access to fresh foods, recommending things like wild-caught salmon isn't helpful. Instead, focus on affordable, nutrient-dense options like canned beans, frozen vegetables, buying in-season produce, brown rice or oats, and bulk lean proteins like egg, canned fish, or chicken thighs. We also need to be sensitive to food deserts or patients relying on corner stores. In those cases, connecting patients to community food programs, mobile pantries, or WIC SNAP nutritionists can really make a difference. And finally, we can't forget about comorbidities. For type 2 diabetes, we want to prioritize carb control, low glycemic options, and high fiber. For chronic kidney disease, we want to be mindful of potassium, phosphorus, and protein sources. And for cardiovascular disease, limiting saturated fats and sodium. At the end of the day, we're not trying to make perfect eaters. We're trying to meet patients where they are in a way that respects their lifestyle and health conditions. There are several great tools also that are out there to support patients in between visits. There are visual guides like the plate method or portion control graphics. There's also plenty of apps like MyFitnessPal or Carb Manager that can be useful for food tracking, Eat This Much for meal planning, Fooducate for label reading and healthier swaps, Referring to a registered dietitian is ideal, especially one that is familiar with liver disease. If your system has care coordination or virtual visits with dietitians, then definitely use them. I also like to use printable handouts, especially for lower literacy patients. Simple infographics can go a long way. And remember, just setting the expectation that nutrition will be an ongoing part of the conversation helps normalize it and keep it on the radar for patients. It's also really important to address liquid calorie intake and processed foods as a key component of nutritional counseling for MASH. For many patients, sugar-sweetened beverages and processed foods are the primary driver of both weight gain and metabolic dysfunction, even when they're not overeating in general. I typically start by talking about soda, juice, sweetened coffee, tea drinks, and energy drinks. These are high fructose sources and directly linked to hepatic fat accumulation. Even healthy smoothies can be problematic depending on what's in them. Then I shift my focus to talk about processed snacks as well as refined carbs. Think chips, cookies, white bread, and fast food. These spike glucose, promote insulin resistance, and offer little satiety. I typically say, let's not just focus on eating less, let's focus on eating better, starting with fewer liquid sugars and fewer ultra-processed foods. For patients who drink sugary beverages regularly, that's often the single most effective change that they can make. But it's also important to address something that flies under the radar: diet sodas. Many people think that switching to diet soda is a healthier choice because it has no calories or sugar, but that's not really the case. Artificial sweeteners in diet sodas can disrupt the gut microbiome and it can impair insulin sensitivity. They can also increase cravings for sweets or high caloric foods, making it harder for patients to stick to their dietary goals. Additionally, regular diet soda consumption has been linked in some studies to higher rates of type 2 diabetes and cardiovascular disease, conditions that often coexist with MASH. So the best advice we can give is to limit or avoid all sweetened beverages, whether they're sugar sweetened or artificially sweetened. However, this may need to be done in a stepwise approach, slowly decreasing the amount per week or sometimes even per day, with the ultimate goal of 0. So to recap, for patients with MASH, our role goes far beyond telling them to lose weight. It's about helping them understand how food impacts their liver, meeting them where they are, both culturally and financially, and giving them the tools to actually make sustainable changes. If we combine evidence-based guidance with empathy and flexibility, we can truly help patients to halt or even reverse the course of this disease. Thank you for listening, and for other educational content, please visit the MASH Community Network.